So once again, I welcome us to today's meeting. We're looking at a very, very important module in FOM, though very silent as we mentioned before. And it's good that every mentor here should be conversant with all the modules we have in FOM. So just by introduction, CTS, just like we know, is a short form for Corneal Topography System. And it's one of those systems that we as optometrists should have as far as it concerns the diagnosis of some of the corneal diseases, particularly corneal ectasias. We may not find it very common because, just like I said earlier, maybe the skill to diagnose some of these corneal ectasias may not be there, or we may find other means for diagnosing corneal ectasias, maybe with the use of slit lamp, and also other forms of techniques. However, this is one of those techniques that is very, very, very important as far as diagnosing corneal diseases, particularly corneal shape, changes. And so it will be very, very important that we know this technique. So that's just a quick way to introduce you to this module. Now let's look at some facts about the cornea. You and I know that the cornea is one of the most, in fact, the highest refractive surface or refractive component of the eye, having about approximately around 42 or so diopters. And also, you and I know that it has about 6 layers. We have anteriorly, we have the epithelium, we have the Bowman's membrane, we have the stoma, we have the descendant membrane, we have the pre-descendant membrane, which is also known as the Breuer's layer. We have the descendant membrane, and of course, the endothelium. So it has both the anterior surface and the posterior surface. So the anterior surface actually has the highest curvature because it's more curved anteriorly compared to posteriorly. And the curvature anteriorly is about 48.6 diopters. Then the more concave, the anterior surface is actually more convex, while the posterior surface is more concave, giving you a minus, dioptric power. So minus dioptric power about minus 6.8. If you do the maths, you'll be having around, say, 42 point something diopters. And that's the average corneal power. The cornea is, of course, normally responsible for 70% of the refractive power of the eye. I've said that before. And yes, this is one of the things we discussed last time. When we're talking about pachymetry, that we said it doesn't change. I think that slide actually said it doesn't change. Pachymetric value doesn't change with age. But thank God for the material that our NC sent to the platform. Studies have actually proven that there's some form of changes as one grows older. Sorry? Somebody said something. Was that for me? So I think that's
go ahead, sir. Go ahead.
So, but studies actually show that there are some changes that occurs as you go older, as far as your cornea. Not just the cornea. I think that's coming from Prof. Let me see if I can use
Yes.
So just a moment.
Okay, I think it's Prof. It's like television.
From Prof. I've muted her.
Okay. Okay.
Okay, so the cornea changes with age, both in terms of curvature and of course in terms of thickness. So we need to know that. So it flattens about 0.5 diopters at around age 30 and steepens at about 1 diopter at age 70. So you see that the cornea stiffens more as you go older. In adulthood, the cornea stiffens by about 0.5 diopter vertically. So at that age, there's a high incidence of with the rule astigmatism. Remember when we talked about keratometry, we discussed all the classifications of astigmatism. And we said one of the classifications is based on steepest meridian, and that will give us whether it's with the rule or against the rule. We said when the steepest meridian is on the vertical meridian, that astigmatism is called with the rule astigmatism. And while if it is steepest at the horizontal meridian, is against the rule astigmatism. Okay. So as one goes older, there's a tendency of having with the rule astigmatism according to literature. Also, some cornea, most of the cornea is actually prolate shape. Prolate then talks about it being steep at the center, and as it goes towards the periphery, it flattens out, compared to an oblate surface where it's flat at the center, and when it goes towards the periphery, it's more steep. You don't really have more oblate surfaces, though you can find some, but the most common and the most normal is the cornea as a prolate cornea shape. Also, an average thickness of the cornea is around 45 microns, plus or minus 5. Just like we said also when we're talking about pachymetry, we said that for blacks, this is the value for blacks, while globally you may have it as 535 microns. Okay, but we are African, so let's use what works for us here. Also, the thinnest side is located on an average 0.9 mm from the visual axis. We also mentioned this during the keratometric class. So we told you that the apical center does not necessarily mean the center of the cornea. And also the center of the cornea does not necessarily mean the geometrical center of the cornea. These are three different parts, three different points on the cornea. Okay, so the center of the thinnest point, which is most likely or most of the time the highest point of the cornea, is usually 0 points off center. So it's eccentric. Okay, it's about 0.9 mm away from the visual axis, and it is usually displaced downwards, slightly downwards. Okay. So what is corneal topography in itself? From the word topography, it's actually an English word basically that talks about studying of surface. Okay? It's a procedure that looks at how smooth or rough the surface is. The geographers use that a lot, try to see the plane, how a land flattens or splittens, or how it bombs, and all of that. So looking at what corneal topography is, we're looking at the study of the cornea, how smooth, how rough, how curved the cornea is about. So we're looking at basically the shape of the cornea. And it's actually a non-invasive technique. You don't need to go into tear the eye open to assess that. It's a non-invasive, it's very safe and easy to carry out. So it's used to actually describe the anterior surface of the cornea. That's corneal topography. Then corneal tomography goes a bit deeper than corneal topography. Just like we hear OCT, optical coherence tomography. So the word tomography there doesn't just look at surface only. It gives you both anterior surface and posterior surface information. So it studies both the anterior surface and the posterior surface in this case. So corneal tomography talks about giving you information about the anterior surface as well as the posterior surface. So it gives that's why you hear of tomogram. The tomogram, when you hear of retinal tomogram, you have information of what is happening at the surface and what is happening underneath. So that's what corneal tomography is about. So the difference between a topograph and a tomogram, or corneal topography and corneal topography, is the fact that corneal topography gives you much more information than the corneal topography. All right. So the normal corneal topography we said is usually steepest centrally and gradually flattens out at the periphery. That's a prolate cornea. Okay? So that's what we described. So prolate cornea usually have a steep apex, flat periphery, flattens progressively from the center to the periphery by about 2 to 4 diopters. Also nasally flattens, the nasal area flattens more than the temporal area, while for oblate corneas, they are flat at the center and they are curved at the periphery. So this is the picture of an oblate and a prolate cornea. What are the applications, clinical applications of corneal topography? What are the, why should you send for corneal topography? What are the indications for this procedure? One, when you suspect the corneal ectasia just talks about an abnormal shape of the cornea. If you do your slit lamp and you don't see that regular curve, you know, as when you see the first picture image as a composite image of the cornea, if you don't see the regular thing you usually see for normal eyes, then you should suspect corneal ectasia. You can also do corneal topography when you're screening for refractive surgeries. If you want to know, for example, high myopes that want to go for some form of refractive surgeries, this is a procedure that must be done for them to ascertain how the shape and, of course, the thickness of the cornea. Also, after corneal refractive surgery to evaluate the success of the procedure, CTS is also very important. There's, of course, the evaluation of irregular astigmatism, especially after penetrating keratoplasty, whereby you reduce the thickness of the cornea as it relates to correcting refractive errors surgically. And of course, in contact lens fitting also, for very, very serious, but when I mean serious now, I'm talking about some form of specialty contact lens fitting, not the regular spherical contact lens we fit. There are some contact lenses we run with fit for, say, keratoconus or PMCD or some form of very effective corneas. You need the CTS to guide you as it concerns the fitting. And of course, for post-refractive cataract surgery is also very important and indication. And also it's very useful in incision placement as it concerns intrastromal corneal rings. We call that corneal intact. It's actually a procedure in corneal semicircle rings inside to stretch out both superiorly and inferiorly, or basically generally depends on what you're trying to the kind of astigmatism you're trying to correct. Is it with the rule or it is the rule? So if it's with the rule where the steepest meridian is vertical, so the see one above and see the other one below, try to stretch, the very steep vertical meridian. And if it is horizontal, we see it here and here, try to stretch with very steep horizontal meridian. So you do that, you use this procedure to actually evaluate such refractive procedures. What are the principles, or what is the principle for corneal topography systems? It's actually divided into two main principles to discuss that later. But before then, let's look at the components of the CTS system, as the corneal topography system. One of part of that system is the projection device. So here you have light, blue light precisely, of course with some form of Placido rings. Okay, we call that a projection device, where this concentric circles. Remember, the eye of the cornea is circular. So you want to identify how smooth or rough the cornea is. So you must project something on the cornea, and okay, I'll leave that one out. When I'm explaining the principle, I will dig into that more. Okay, so this is the first projection. This is the first main part of the CTS. The second part is the acquisition device, okay, where it now gives you an information. It's capturing data, and it can be video keraitoscopes, it could be a slit system, stent plug, or your spectral luminosity as seen in your spectrometer. So We have the acquisition device that acquires the information that placebo risk has given. And lastly, we have the analytical device. This is what converts whatever has been projected on the screen and whatever has been acquired by those devices into usable information. So that's the analytical device. So these principles are into two, like I said earlier. First, we have the reflection-based topography system and the projection-based. They're a bit similar, but there's a difference. Now, in reflection just talks about projecting ring-like, lights in front of the cornea, and of course, the transparent surface, of course, that have the property or the characteristics of reflecting back whatever is shown on it. So when or light in the cornea, the reflection that the cornea gives helps you to assess how smooth or rough it is, tough it is. Okay, that's for the reflection-based system. However, in the projection-based system, what you do here is that you project, just like you do your projection, you project light through slits, through circular slits. Okay, so you're not projecting the the concentric circles now. You are projecting light through concentric strips onto a surface. Now, in this case, it doesn't really matter if the surface is transparent or not. Okay, so because you're not looking for reflection now, you're just projecting light that goes through concentric circles on a surface. And how smooth or rough that surface is will be determined by the projection or how the image is projected on that surface. So what it means is that for reflection-based, only transparent structures can be evaluated because it must reflect like that for it to be evaluated. But for projection, you don't need a transparent surface, not necessarily transparent surface. So that is why you see corneal topographers, some corneal topographers, not all, can get as large as 12 mm, even going towards the limbus, and give you information on how smooth the limbal area is, which is usually not transparent. All right, so you can have that. So these are the two systems that we use. So for the reflection base, I said it projects something like this. So this is a light, it's a reflection that is projected on the cornea, and it uses this to give you the smoothness or roughness of this. So this is usually done in a transparent or a and that's what is used to assess the information. But however, sorry, I'm actually outside so that I don't get issues of the network. So permit the surrounding noise. That's a thunder or lightning that just struck. Hope it's about to rain now. Okay, so I've explained this. So let's quickly move on because we don't have so much time. We have two parts actually in this module, part 1 and part 2. So I would like us to quickly finish both parts tonight. So I've already explained all of this. So let's quickly move on. For the projection, like I said, you project, the image that's like scanning through a slit image, on the cornea, just like we see here. So you see these concentric circles are actually in slits form. So it is this that is imaged on any surface, and that is used to acquire how smooth or rough that surface is. Okay. So let's quickly move. These are the two systems that it uses. One of the benefits that this projection can do is that detailed accurate measurement over a large area, including the limbus, okay, and from very irregular or non-reflective surfaces. So it can even give you information, depending on how large the projected image can get to. Even if it gets to the sclera, it can also give you some information about how smooth or rough the sclera is. So examples of that is your laser interferometry or your raster stereography. All right, the data measurement and presentation by corneal topography systems. I've already mentioned these two methods, reflection and projection method. So this is just a So the projection actually gives you a height. That's very important. Gives you not just only curvature, but it gives you information about the curvature based on height, and that height gives you curvature both global and local. And of course, that gives you you can use the sky to get the dielectric power. So the reflection base uses slope this time around, and of course that gives you the radius of curvature, and of course you can convert it to dielectric power, and that gives you the information you need. So we have different types of corneal topographers. They are actually broadly classified as keratometers. Keratometers is actually a form of a topographer because it gives you information about the curvature of the cornea, though it's quite limited because it majorly gives you, about 3 to 6 maximum, depending on how the brand of your keratometer. But it can give you up to 6 mm, information about the central cornea. That's an example of a keratometer. We have a keratoscope, which is this with concentric rings, and of course an inbuilt light that gives you the information. Now, if you look at this is like a reflection, and this is like a projection. These are slits where light can actually shine your regular torchlight through it to project circular slits on the cornea, and that can be used to give you how smooth or rough the cornea is. These are actually the manual ways. So you have to use your own understanding to check. And how do you do that? Using this equipment. Areas that are the concentric circles that are broken, okay, are actually those areas are not smooth. As regular, where the circles are not broken, are actually smooth. Okay, so that's your keratoscope. You have your video keratoscope. This one gives you, it interprets itself. It's not manual, it's automated. It gives you information just like we mentioned before. It acquires the image and of course converts it into information. We have two broad classes, new generation and the old generation. These here are the new generation topographer. So your OCT can be classified as a topographer. The reason is because anterior segment OCT gives you information about the cornea. It tells you how curved and how thick the cornea is. It may not give you other information about localized curvatures. It gives you global curvature and of course thickness, but it gives you of course localized thickness. Okay, particularly the opto view. Not all OCT does that. Some don't give you information as that, but the one I have worked with gives you localized corneal thickness as well as global corneal curvature. While the old ones include the keratometer, your button lamp, your placebo disc, but this is the same that is similar to your keratoscope, like I showed you earlier. All right, so okay, we've talked about the modern ones. These are the modern corneal topographers we have. So I'll just rush through this. These are not very, very necessary, but just for us to have an understanding of some of them, their uniqueness, their peculiarities, and all of that. So for the raster stereograph, what it does, it helps to analyze the entire corneal surface, including the optical layers, the cornea adjacent sclera. So you see, and of course, it does that using the projection system, not the reflection system. It works well in non-reflective or irregular surfaces such as scarred or serrated corneas. So now the cornea that is not transparent can actually still be measured. So you could actually measure the curvature, but using the projection system, not the reflection system, because at that point it may not be able to reflect, any image. The tear film is stained with fluorescein, and a light grade of parallel lines is projected through a cobalt blue filter onto the surface that you want to measure. That's for the raster stereograph. An image is obtained due to the video camera and of course analyzed digitally. And this measures the entire corneal surface up to 12 mm. So you could see it will give you that wide surface area. This is how the raster stereograph looks like. And this is the way it gives you the information. Okay, we'll look at this for the part 2. I think this is actually the main thing of CTS, how to interpret the results. So we'll look at that as we move on quickly. Now, what you see here are different corneal shapes using one of the maps, which we're going to be talking about later, okay, called the curvature map. Excuse me. So one of the things you'll be seeing as you move on is when the cornea is uniform in shape. So here you don't have any form of astigmatism. This is a spherical cornea. What you have is what you see in picture 1 here, and for picture 2, there's some form of astigmatism, but the astigmatism you see here is symmetrical. Okay, so you have the symmetrical astigmatism here. In 3, what you had is non-symmetrical. We call this non-symmetrical bow tie, where you have a superior steep bow tie. And here you have an inferior steep bow tie. It's also asymmetrical in nature, not symmetrical. As you can see here that the inferior is steeper than the superior. And also something is also unique about this particular one. You see that it's not, it's skewed towards one area, skewed to an area. That shows that it's actually an irregular form of astigmatism. Okay, so it's an inferior steepening of the cornea, and that is typical of the condition we call keratoconus. Pentacam is actually one of the very, very latest topographers we have. Very, very useful, and it gives a lot of information. It's one of the uniqueness is that it can actually do what we call the BAD map, the Berlin and Brochure map, where it analyzes and gives you some form of monitoring as time goes by. That's how the pentacam looks like. So it gives very diagnostic data on the entire corneal segment, and it's very fast, few seconds. It measures both the anterior and posterior corneal surface, and of course gives you the total refractive power and the total thickness. Unlike the conventional topography system, the pentacam measures elevation data rather than just giving you curvature values. So it gives you what we call elevation map. I will discuss that as we move forward. It helps in detection of aesthetic corneal changes. Like I said that earlier, it can track changes actually and tell you how much changes have occurred over this time you'll be managing this patient. What's the advantage of this particular topographer? High resolution of the entire cornea, ability to measure cornea with very serious irregularities, and of course, it can give you pachymetric values from limbus to limbus. This is how it looks like. I know this slide is very busy, or this image is busy, but we'll break it down as we go forward. The OpScan is another very important one. It's also a modern topographer. What it does, it gives you, of course, similar to what the pentacam does. I just want to run through this. No uniqueness about this, but similar to that. This is the way it looks like, giving you both the curvature map and, of course, elevation map, as well as the thickness map as seen in this photo. Now, what are the display colors of corneal topographic map? It's usually 2D color map format. Steep areas usually have hot colors like the red and orange, while the flat areas have cool colors like the blue and the purple, as seen in this key here. So most of the corneal topographers, the printouts, they have a key that will guide you on how to interpret these colors. This is another one, another type of topographer. Now, there are also some scales that can be used. We have the absolute scale and the relative scale. For the absolute scale, it's actually standardized, and same color represents the same power on every map. So here you cannot alter the changes. You cannot determine the grade. For example, if it comes say from 0 to 5, let's represent that as blue. So then from 5 or 6 to 10, let's it's the lighter blue like that. You cannot alter it. However, for relative scale, yeah, you can actually adjust the scale, and determine the the level of the difference in diopters. Okay, you could actually check or call the step interval. You could determine that by yourself, and of course use it to um, let the machine interpret it based on what you want it to do. So sometimes the advantage it has is that you may see you may want to say, okay, 0 to 1 diopter, let it have 0 to 1, let it have 2 diopter differences, in the scale, so that we can be able to differentiate very, very minute differences as compared to the absolute scale that is, not adjustable. Of course, we also have some statistical indices. Of course, in every printout, you must have some form of statistics based on normative data. Okay, there are single figures which summarize a particular feature of the cornea, such as the symmetry, regularity, and asphericity. Here is good use for studying a group of patients and making comparisons. Types of corneal topographic maps. Here we have about 4 types of 4 maps that is seen in the printout of your corneal topography system. One is the curvature map. We have the elevation map. We have the power map, and of course the thickness map. We'll look at them one by one. The curvature map, just like the word is, it just tells you how curved as a steep or flat, stiffness or flatness of the cornea surface. Now you can display it in 2 forms: sagittal, from the sagittal dimension or tangential dimension. These are just ways you look at images. Okay, for sagittal, here you're looking at it from up to down vertically. Okay, and for tangential, you're looking at it from side to side. Okay, so depending on how you want to view the cornea, that's what you ask for. So if you ask for it to present it sagittally, it will present it. Why? If you ask it to present it tangentially, it will present it. Okay. It does not show much information other than maps. It cannot show you minor variations in corneal curvature. This map can also pinpoint the position of corneal defects, such as the cone location, as seen in the cones. Here it uses colors to represent curvature and dielectric power. So I've said that before. Cool colors is depicted as blue. Hot colors is depicted as orange and red. So the axial or sagittal curvature map is less noisy. It's actually very straightforward. It's good for having an overall view of the cornea. And of course, it can use it to monitor some form of changes or irregularities as time goes by. However, the tangential map is a bit much more complex. It's noisier. However, it's more accurate to determine curvature. So you select the correct tangential map if your focus is curvature. You want to check for either usually local curvatures, and of course it's good for locating where the cone is or where the steepest point is. Just to mention very importantly, as the area of steepness, where you have steepness of the cornea, that's usually where the cornea is usually thinnest, because as the cornea thins out, if you look at the structures, the anatomy of the cornea, the stromal bed is actually the fibrous, the fibrous structure of the cornea that gives it that strength, that gives it that firmness. And from my experience, back prior to this knowledge, I used to think that the cornea is one very tiny, thin.
Can we still hear him?
I can't hear him.
Can't hear him.
Hello, Dr. Saze.
treatment of corneal ulcers over the years has actually given me.
Okay.
Hello, sir.
Audio is back again. We lost you before. We lost your audio before, but I think you are back now. The last thing we heard you before now, you said you used to think that the cornea is a thing and your sound left. Hello? Hello?
Can you hear me now, sir?
Yeah, we can hear you now. Go ahead, sir.
Okay. I'm using my second device to. What about now? Can you still hear me?
Yes, we can hear you.
Are you still with us, sir?
Okay, can you hear me?
Okay, you are back now. We can hear you now. Can hear you now.
Apologies. I'm sure you can see my screen again. Let me quickly share. I'm sure you can see my screen now and you can hear me clearly.
Yes, we can.
All right, thank you, sir. So I was trying to explain that the perception that we as optometrists have is not far-fetched from what the regular regular layman in the street has about the cornea or about the eye generally. In fact, I heard one of our colleagues one time said something about telling the patient that if you don't treat the pressure in your eyes, the patient has high intraocular pressure. Said if you don't treat it, the pressure can be so high that the eye will just burst like a balloon. Oh, that's yes. You may say that just to put some fear in patient, which also has its also demerits. You don't do that because today patients are now more informed. So the point I'm making is that the cornea is not as fragile as we think it is. And I was saying that from my experience in removing cornea foreign bodies, treating corneal ulcers over the years, treating recurrent epithelial erosion where you have to remove all the epithelium, to allow new ones to grow and all of that. The cornea is actually very, very fibrous, very strong. If the object is not sharp enough to penetrate through, it will not burst. So the point I'm making is, as that fibrous area, which is a stroma bed, if that fibrous area begins to thin out, what will happen is that anywhere that is thin will automatically stiffen, okay, because of the pressure already within the eye. So if that stroma bed thins out slightly, the pressure within the eye will push that area out. So you see that thinness is usually synonymous with stiffness. I don't know if that makes sense. Right? And that's what you see exactly in keratoconus, where there's gradual thinning of a particular area of the eye, of the cornea precisely now, and that area just bulges forward naturally because it thins out. Okay. And one of the ways to actually address that from progressing forward is to do what we call corneal cross-linking, where you have to try and strengthen the stroma bed, creating an epithelial flap, use some riboflavin and expose to UV rays to thicken the stroma bed. At that point, you see that the cornea becomes more strengthened and it doesn't progress further. So what I'm trying to say is that when an area is more curved, that area, the most curved part of the cornea is actually the most steepest part of the cornea. Please take note of that. So I was talking about curvature maps. So curvature map looks at the shape, whether it's round, what is the cornea round, the corneal oval. Now this is a round, this is a curvature map that depicts a round cornea. And you can see that this area here is the steepest area, the apex, that's the most apex.
Can anyone hear him? I can't hear him anymore.
We've lost him again. His network is fluctuating. Leave the light on.
You can't hear me again, Dr. Daffy.
Yeah, now, yes, you are back now.
And I'm
lost
using
you
my
before.
second device. The main device has gone out. Okay, let me quickly change the network of that device and see if it will be better. Right. I'm sure you can hear me now, sir.
Yes, we are hearing you now. But we can't see your screen.
Okay. Yes, let me share it. Sorry about the network challenge. I need to quickly rush now because we need to finish this next 30 or so minutes. All right. So I'm sure you can see my screen now.
Yes, we can. Go ahead,
All
sir.
right. Thank you very much. All right. So so I was saying that the cornea can be, the shape can be round, it can be oval as seen in this photo here. This is an oval shaped topograph. We have, it could be superior steep, where you have astigmatism in this case, so it's not curved, it's not evenly curved. You have an area more curved, either the superior is more curved or the inferior is more curved. Here, the superior is more curved or more steep, so we call that a superior steep um, graph as seen in this photo here. And here it's asymmetric because you have more steepness superiorly compared to inferiorly. You can see this tiny small here. It's not as compared to what you have superiorly. You also have similarly inferior steep as seen in this photo. And of course, you have the irregular bow tie where the cornea does not have any shape. It's just too irregular. We call this kind of corneas or astigmatism higher order aberrations. And this is usually seen in addicted corneas where patients really don't find vision funny. They may be seen largely, but minutely or microscopically, not really. Getting fine details, it's not for them at all. So when they look at faces look very, very, they can see the shape of the face, but they cannot place contours. They cannot exactly see what's happening, within that space, and that's really a problem. for them. Okay, that's a symmetrical bow tie, as seen in this photo here. So you see that both the A and B there have the same shape, and that's why it's called symmetrical bow tie. We also have symmetrical bow tie, but they are skewed. They are skewed in their radial axis, as seen in this photo here. You have them skewed to one side, based on where the irregularity is coming from. So here you find that the difference between both meridians is less or more than 90 degrees, as is seen in your regular astigmatism. So most times you find out that the difference between the principal meridian and the other meridian, if you do your graph, if you draw a line as seen in this photo here, if it's greater than 22 degrees, then it's usually called a skewed, skewed symmetrical bow tie. However, if it's less than 22, you may not classify it as skewed. So this is a bow tie that is not skewed; it's symmetrical. This is another one. I would have said, let me ask us questions, but we don't have the time to do that. This is an asymmetrical bow tie. As you can see here, the bottom is steeper than the surface and is also skewed. But for you to know if it meets the definition of it being skewed, you must measure and see that wherever it's skewing to, the angle it makes with when you draw a line straight here, if it's more than 22 degrees, then it's classified as being skewed, just like we see that first line and the second line. So if that's this angle here, so you can see my cursor, this angle here that these two lines makes, okay, is it more than 22 degrees? If it's more than, then it meets the classification of it being skewed. All right, so we have a symmetric bow tie inferior tip. This is how it looks like. There's a lot of pictures in this slide, so just have to quickly run. This is a superior asymmetric bow tie. This is also another asymmetric bow tie, but it is skewed, okay, just like I mentioned earlier. Then you also have the butterfly, something like this. Okay. Here now, the asymmetry is not vertical. The asymmetry is now, horizontal. Okay, where you have the astigmatism on this, one side is less skewed, is steeper than this other side, or they are likely to have the same level of stiffness. Call that a butterfly map. We also have what we call the crab claw, as depicted in this photo here, or your kissing bird. Okay, you have something like this. So you see as if it's a crab claw here, or two birds are joining their beaks together. It's also another type of a crab claw or kissing bird. Then you have junctional. Let's move on. This is junctional one. You have a vortex, like a wild wind, and there are things moving inside the wild wind. You also have something of this nature. So all of this just depicts, an abnormality. Okay, so you must know what a normal cornea looks like. Then when you see an abnormal curvature, it will be easy for you to identify. So in corneal topography interpretations of abnormality, the following parameters you can note. First is that the superior and inferior area must be equally related. Okay, around the central 5 mm. So if you look at this, the curvature superiorly and inferiorly within the 5 mm radius centrally, they must be equal. If they are not equal, then they should meet these 2 and 3 parameters. So if you subtract the inferior curvature from the superior curvature from the inferior curvature, it should be less than 2.5 diopters. If it's more than 2.5 diopters, it falls under an abnormal curvature. While if you subtract the inferior from the superior, it should be less than 1.5 diopters. Now, somebody may ask why the lower one? Remember I told you that in a normally there's some form of the apex of the cornea, which that amounts to the steepest part of the cornea, is usually not centrally located. It's slightly displaced inferiorly. So usually you may have some more inferior stiffness compared to superior stiffness. Okay, and that is why you can see variability here. So if I take the superior and I subtract from the inferior, the value should be less than, if it's less than 2.5, good. If I take this inferior, which is steepest now, and subtract it from inferior, the value should be less than, because that is usually the normal. So the limit of values is smaller for when inferior is larger than superior. Okay? So that's why you're having these variabilities. I just hope that I'm making sense tonight. Are we together, please? I hope I'm not talking about.
Yes, we are together. Go ahead.
All right, thank you, sir. Okay, so this is exactly what we're trying to explain. So if you see these the two white circles, this is basically the central 5 mm as depicted by this circle here, this black circle. Okay, now the steepest here, and this is the steepest in the superior part, and this is the steepest in the inferior. You can see that the inferior is actually steeper than the superior. So we subtract the inferior minus superior. If that value is less than 1.5, then it's normal. If it's more than 1.5 diopters, it is an abnormal corneal curvature. Okay. So that's what we just did. So this is 2.1. So this is an abnormal curvature, and you can see even from the colors, you can see that here is actually an inferior asymmetric bow tie, as I explained earlier. Here, you can see that this is an asymmetry too. So let's do that. Here, superior over 2. Here, though it is asymmetrical, but superior minus inferior is equal to 1.3, which is less than 2.5. So this is also fine. Okay, this is still within the normal range, according to what we have in this slide here. Another thing you should also take note that is that the central curvature should be less than 47 diopters. If it's more than that, then that could be classified as an abnormal curvature. Inter-eye central power difference should also be less than 1 diopter, and of course, your maximum K should be less than 48 diopters. That's generally now, not just at the center of the entire cornea. So that's the central cornea, should be less than 47. So using this, you can see that it is still within normal range as mentioned earlier. Here, if you do the same thing we did earlier, you see that, you see that this is way, way, way abnormal. Oops. Wow, it's raining, you know. Hey, I hope it will not disturb us. Doing that is drizzling. Anyways, let's move on. So, yeah, you have inferior minus superior, and this is way, way more than that, and that's an abnormal corneal curvature. Okay, so that's the red thing there, just shows you the K max, that's the maximum K for the entire cornea, and it is 60 diopters. So it shows that it's an abnormal corneal curvature. So that's the curvature map. So simply what the curvature map does, it just tells you how curved, the cornea is. Now, comparing this with what you see in your keratometers. Remember, in your keratometer, you have just one curvature, or let's say at most 2. It gives you horizontal and vertical curvature. That's it. Here, the advantage the CTS have over the, I beg your pardon, just give me 1 second. All right, sorry about that, Greg. So I was just talking about the curvature map and what it does, basically, comparing it to what you get with your keratometers. For your CTS gives you localized curvature. So it tells you the curvature of each point in the entire cornea, okay, depending on the area it can cover. Another map that is also very important is elevation map. Here, it doesn't just talk about curvature, but it talks about height, how high your cornea is. I don't know, can you still hear me clearly? Because it's raining here. Dr. Daffy, please. Am I still very audible?
Yes, I can hear
hello?
you.
Is anyone there? Okay.
Yes, I can hear you.
Please,
We're losing you again.
pardon the background noise. Pardon the background noise. If you can hear me, please. If you can't hear me again, let me know quickly so that I can.
It's cutting off. But it's okay now. So go ahead. Sir.
All right. Thank you, sir. So I was saying that the elevation map basically just tells you about height. Now, it doesn't talk about curvature anymore. It talks about, it just tells you about the height of the cornea. So here, it tells you the area that are elevated and area that are depressed, but it uses a reference. So there's usually a reference point that is used to base its judgment on whether a point of the retina or a point on the cornea, I beg your pardon, is higher or lower than the reference. And the two references it uses is basically one, the best fit sphere, that's your BFS, or your best fit toric ellipsoid, that BFTE. The first one basically, of course, just like it says, sphere is for spherical corneas, while the second is used for toric corneas. However, it doesn't really matter. You could use any one of them, but mostly when you suspect a toric cornea, you use your BFTE. And the images in front of you there just tells you, sorry, I don't know why this thing is coming. Well, excuse me. All right, so as you can see in this photo here, you see that here what it tells you, this is the reference, the yellow lines tell the reference point that this machine has used to classify this elevation map. So anything above this reference line will be seen as elevated, while anything below the line will be seen as depressed or seen as flat or straight. Okay, so that's what it uses in elevation. But please don't confuse elevation from curvature. Okay, it's not the same term, it's not the same terminology. However, they must have a point where they agree. All right. So, sorry, I hope you can still hear me. I wanted to move inside.
Yes, I'm still hearing you.
You can still hear me clearly. All right. Okay.
Yes.
So, so depending on the reference or the line, the reference you're using, is it your BFS or your BFTE, that will now determine how that area of the cornea is higher or not, okay? So if you look at this particular one here, this is your reference. The blue line are areas that are flatter, and of course your red lines are areas that are steeper. Let's move forward. Here also tells you these are areas that are elevated, and these are areas that are, the minus that shows you are the areas that are depressed. So basically what elevation map gives you just tells you a point on the retina, is it higher based on the reference or lower based on the reference. Now if you study these diagrams very carefully, you will see that here the black line now is the reference. So these areas are higher and these areas are lower. Blue lines are low, blue areas are lower, red lines are higher. Here you can find out that none is even. Okay, you can see that none is higher than the other. So the elevation here is basically even for all through the cornea. No part is higher than the other. Here you find that some areas are much elevated compared to some areas. The red areas are elevated while the blue layers are depressed. Now you can see that it's not a matter of whether it's curved or more curved. A more steep area can be depressed. It's possible, okay? As elevation and curvature are not speaking exactly the same thing. Okay, let's move on. So these are maps, these are elevation maps. All right, so areas you have your minus values are depressed, areas you have your plus signs are elevated. So okay, that's it basically. So let's move on. Areas you have your plus are elevated, and areas you have your minus are. So these are much more photos to depict that we have said earlier. Where you have your pluses are elevated, where you have your minuses are depressed. Okay. Same here. So what I was telling you earlier, the two references could be. So why is this thing coming? Okay, so you see here, my cursor here is telling me that they are using the best BFS, best fit sphere. While the second one here and the first one there talks about using your ellipsoid, your toric ellipsoid. So depending on which you want the machine to help you analyze or help you present, that's what we ask for. Garbage in, garbage out. Remember that's the principle of using computers. Whatever you put in is what it gives you. Now let's look at the shapes of elevation map. The shape of elevation map is your hourglass pattern where you have the picture of an hourglass as is seen in this picture here, usually found in astigmatic eye, but still normal eye because astigmatism is a normal shape of the eye. Okay, but just that you have some areas that are steeper or more curved than the other. You also have what we call the tongue-like pattern. This is usually seen in an abnormal case. So when you see an elevation map in this manner, it's usually at some point when I was studying this, I used to get very confused, with these terms, with these terminologies, and sometimes it's just puts me off. So, can you still hear me?
We can hear you now. We lost you at the time,
Okay.
but we can hear you now.
Yeah, it's showing me that my network is not stable. So I was trying to tell you that it's really, really confusing understanding these terms. However, with time, if you keep studying them, especially when you have referred the patient, okay, the patient, for example, for such procedure or such test, and we see the result, it makes more sense. It's not until when I handled or I saw a printout like this. In my former office, we used to have one, and we used it, and that was when CTS became more real to me. And I think this is one of the reasons why a lot of us are not very familiar with these concepts. However, just work with me as we move on and flow. So we also have a kissing bird pattern. We have something like this in your curvature map, different from what we're looking at now. We're looking at another type of map, just like in your visual field where you have different maps. That's the same concept here, where you have different maps, but each of these maps must agree, pointing towards a particular disease or pointing towards a particular defect. That's exactly how it is here too. So this is your kissing bird map or your butterfly map in your elevation map. It's also a sign of an ectatic cornea. When you have central cone pattern as seen like this, it's also a sign of an ectatic cornea. So all you need to look at is to see how far the elevated areas compared to the depressed areas. You can see here you have about -74, -78, and here you're having +88. So you could see the margin is really, really large. Then also, if I'm having +4 and -4, it's not far-fetched, right? However, having such large values shows that the elevation and depression is so far apart, and something is actually wrong here. Cases like this could be there's a central thinning around the mid periphery of this cornea, and this is usually seen in ectatic corneas precisely. So look at the parameters we have here. So for elevation map, the central circle on the elevation map is usually around the 5 mm. So that central circle you see here, let me go back to that one of these photos. So the central circle you see here is actually central 5 mm. Central 5 mm. Values greater than 12 microns on the anterior is actually abnormal. while values less than or greater than 15 mm on the posterior is abnormal. Using these references, using your BFTE reference, okay, that's where you see that as abnormal. Take note also, like I said, you have some corneal topographs like your OpScan and your Pentacam actually give you both anterior and posterior information. So you should be careful to look at the map. It's usually, it will tell you what map this is. Is it the anterior, or some of them will tell you front or back, curvature map, or front or back elevation map. You must be able to identify which is which. Okay, so you can see in this photo here, you can see that this is the elevation front. Is that not so? So this is the front or the anterior cornea, and it gives you that information. And we said that the values greater than 12 microns is abnormal using the BFTE reference, while for the posterior, greater than 15 microns is abnormal using the BFT reference. Okay, so this is exactly what we did earlier, as we did in the curvature map. So if there's a difference between the superior and inferior, it gives you that is less than 12. That is when it is normal. If it's greater than 12 for front, it is abnormal. If it is greater than 15 for the back, it is abnormal. So that was what I was telling you, that most definitely, that one we saw 80 something and 70 something is of course very, very abnormal. Okay, so this is just saying the same thing we said earlier. So for the posterior, we're still saying the same thing. So let's quickly move on. Intra-eye corneal apex, okay, I think I've explained this before, but the intra-eye corneal apex thickness point difference is usually less than 8 microns. That's for the posterior now. Why inter-eye corneal apex thickness point difference? Okay, it's basically the same for intra-eye and inter-eye. So intra-eye is in one eye, while inter-eye is when you compare both eyes. So this is the bad map. We call it the Berlin-Ambrosio Enhanced Ectasia Display, also known as bad map. So like I said earlier, this map is seen in very advanced topographers like your Pentacam, where it helps to simplify not just only the elevation map, but even the pachymetric map also, trying to give you more or less like a regression, analysis, gives you a projection, it projects, and tells you how far this patient's corneal thickness or this patient's elevation map has gone compared to the normal for that patient. So it actually gives you standard deviations from what is expected for that population, and it presents it in a graph as seen here. So this is a bad map. What you see here is a bad map, and this is the graph it gives you. Okay, it plots this graph for the corneal thickness, and of course percentage thickness as seen in the lower graph there. Another map is the thickness map. It's also another map we look at in your corneal photograph. We'll still be done with this first part. I think so. So we said the most important consideration on this map is the displacement of the thinnest corneal location. This is very important. In fact, knowing the thinnest area of the cornea, like I told you, which usually suggests the steepest area, is very, very important in diagnosing some of these cases. Remember, in keratoconus, for example, you need to know where the nipple is. The nipple is where the area where it's steepest. Okay, that area is very important, so that you take note of that. Is it towards the right? Is it towards the left? Is it inferior? How far is it? And all of that from the central cornea. Okay, so interpreting thickness map, consider the shape and the parameters of the map. So the shape will have red and yellow equals thin, and of course equals an abnormal cornea, while the areas that are green shows uniform thickness, and that's for normal corneas. Using this map, the following should be considered. One, if there's a difference between the superior and inferior thickness value greater than 30 microns, less than 30 microns, I beg your pardon, the difference between the thickness map of both eyes should be less than 30 microns for you to consider it as normal. If it is more than that, then you are looking at an abnormal cornea. check for the y coordinates. Okay, you'll see that in the map as we move on. If the y coordinate is less than 500 microns, then the cornea is normal. If it is between 500 to 1000, then the cornea should be suspicious. Why? If it is greater than 1000, then that's actually an abnormal cornea. The thinnest point displacement from the apex and from the apex and from the pupil center should not be more than 0.9 mm. I think we mentioned that before. Sources of errors. One, alignment error. This is very common for most machines or most procedures we do. You must align the eye very well for you to get, the exact or the correct information. Tear film irregularity. In fact, this is one area I remember back then. Before we perform that procedure on the patient must sit down and we'll put wetting drops. We'll wet that eye for about 5 minutes before the patient goes into the procedure. Because why? We need a very smooth surface. If you come to see that assessing the smooth surface is one of the reliability indices, even for this procedure. Okay, so you must have a very regular tear film. Otherwise, it's going to give you an error. Of course, improper focus is another error. Pressure on the globe, it can give you error, can make the cornea too steep or too flat, depending on how the pressure is applied. Poor tear film, just like we mentioned earlier. Lubricating drops. If you don't put enough lubricating drops, you may not get the right thing, because what you are looking for you to actually get the smoothness, for the machine to capture the smoothness of the cornea, is to ensure that that cornea is as smooth as possible. Then when the patient is not opening their eyes properly, where the lashes is still being viewed, that can also cut out some part of the map. Remember that the entire, some machines actually get up to 12 mm. That's really wide. And so if the patient is not staring to raise the lids up, it can capture the lashes, and that could cause some form of artifact and result in some of these errors. So when you see anything like this, you usually ask for a repeat or you reject the results. So you can apply this procedure for keratoconus to early detect keratoconus, describing the location of the cone or the nipple, as I explained earlier. Monitor changes by the use of your bad map, as your Berlin and brochure display. For refractive surgeries, like I mentioned earlier, contact lenses. In conclusion, corneal topographers are quite expensive, and we know that. However, the printouts are cheap. Patients can send you their printout that they did in Canada or in the UK, and they ask that you interpret it for them. I think that should be enough. This information that we're having tonight should be good enough to explain what that printout is talking about. And so let us take time to know this to help our patient better. So thank you for your attention. I'll quickly run through the other parts. Wow, it's almost 10 p.m. All right, so this is part 2. I hope we're able to finish before 10, but I just have to rush as quickly as I can. So please pardon me. So now we're going to be looking at the interpretation proper. Okay, Dr. Ohabike's hand is raised. Are we entertaining questions now? Or you want to make a comment on or an observation? Okay, let me allow you to speak.
Dr. Osazee, please there.
Okay, ma'am.
I don't know. I'm just trying it open. Are we doing this to tick a box? Because CTS is what is not very familiar to us. And so my suggestion is that we don't rush it. We took how many minutes to do part 1? My suggestion is if we can move part 2 to the next one, it's better. So that if people have questions, we've not written posters. People have not asked questions. We barely have 26 minutes. So starting part 2 now, interpretation, which is the slide number is even more than the first one. That's my suggestion.
I agree with you completely. I agree with you totally, Dr. Habike. I don't think the essence is just to tick a box, just like you mentioned. Even though this is upgrade and we believe we have knowledge of the CTS already, but I think this is one area that we've not really explored. I mean, our mentors. So it will be useful to have another day to go through the part 2, because this part 2, I know, is the most important part, which is interpretation actually. So I think it's better we have another day. It's about sacrifice. I know why Dr. Osazee has to also go through to complete it, because you see how difficult it is for us to even do the regular, the meet up with the time and the schedule. It's been quite difficult. But if all of us agree, we can pick another date and finish the second part. So we don't just rush it for the sake of taking the box. That's also I was going to mention that before Dr. Habike raised her hand. But it's left for us to decide.
Well,
I think
as
I agree
presenter,
with
the truth is
Dr.
that
Gochi and our NC. I think we should have that for another day, the part 2.
okay, absolutely. I can't agree less with what we have said. The truth be told, this is really the main thing. The first one was just a scratch on the surface. There's a lot to talk about in this part 2. So maybe what I'll just do, because of the post-test that except we can leave out the post-test. Well, I'll just maybe mention one or two things so that we can quickly answer the post-test and we'll close for tonight. And then we'll look at this part 2 much later. I don't know if that's okay by everyone.
Unless if your post-test is different from your pre-test. If your
Yes, there are two questions. There are 2 questions I added, so I'll just explain that then. We answer it and we close so that we'll have another day for this.
For me, I would think we should just stick to the ones you've already done.
Or
So that
I
we
would edit and just take a
do the ones, if the pre-test covers what we've done in part 1, I would want you to just, okay, let's just look through that so that by the time we not do this part, we can now use this one on the next class. We'll now use the post-test as the test for the next class. That's my suggestion. I don't know if you understood what I just said.
I didn't get you, sir. I only heard you the last. I only heard you the last part.
Okay, I'm suggesting instead of not touching here, because trying to explain one or two things here because of what you want to do. We've not crossed into the part 2. We are trying to say let's not get into it. And the reason why you want to do that is because of the post-test. So my suggestion now is that if your pre-test was actually captured in the part 1 that we did, why don't we visit the pre-test as the post-test for this one? Okay. The pre-test that they did before, let it be the post-test for this one. Then when we now go to the second one, we can now use that one as pre-test and post-test for the part 2.
That's fine. That's fine. It's okay. It's okay.
My suggestion, if our faculty chair and our NC agrees with it, for the want of time.
That's not the problem at all. Yes. That's not the problem.
Absolutely. I think I agree with Dr. Gaffney.
Okay.
Okay. So Dr. Osazee, let's have the post-test again so that we'll do that quickly. Then you review it with us.
Okay, that's fine. Well, in the meantime, do we have any questions based on the presentation? Questions, comments, contributions? So we can attend to them as we move forward. So this is a pre-test that is serving as a post-test now because of the recent development. So we can go over it again and just forward your answers.
I have a question, Dr. Osazee. So, do you think the CTS covers both corneal, excuse me, excuse me, both corneal topography and tomography. I know that of OCT, yes, covers tomography, corneal tomography. But some other CTS maps I've seen are essentially topographic maps. So why do you think tomography is part of it? And which other CTS covers that apart from the OCT specifically?
Okay, I actually mentioned two of them that has the tomographic ability. Yes, basically, a typical corneal topographer, just like the word topographer, is a topographer. So it just gives you information about the anterior surface. However, we have some that have improved on just giving you topographic vision and giving you tomographic. So those particular ones, we don't call them topographers anymore. Okay, we call them tomographers. Example is your OpScan, Pentacam. These two actually gives you information about the front and the back surface of the cornea. And that itself makes them pass to be called a tomographer. So outside the regular OCT that we have, even the OCT is also limited because not all OCTs gives you anterior information or anterior segment information. Some of them are just basically for posterior segment evaluation. Just a few of them that can still give you anterior segment information. So basically, it's the topographers are topographers that have the ability to do the posterior segments are few, and they're usually the modern types. I don't know if that answered the question, sir.
Okay, thank you. So, but I know most of the maps cover essentially four aspects of the cornea: thickness, the curvature, elevation, and the power. So do you think, which of them do you think is captured under the tomography out of these four?
Okay, so,
and then of course,
yes.
yeah, and of course the Pentacam that does the bad analysis.
Okay, so for you to actually know if that topography or topographer rather has that ability, when you are presenting when it's presenting its results, if you can, it has a function of asking of giving you if you want the front surface information or the back surface information. Okay, so for the elevation map, for example, usually the curvature map, let me start with that. The curvature map, you don't really need the back surface here because although in that some of them can still give you, but just like I mentioned earlier, the front surface is actually a major part because the front surface is about 40 something diopters, right? While the back surface gives you a minus because it's more concave. So for the curvature map, you usually have basically the front surface. But for elevation map and also for thickness map, you may have both front and back. So what distinguishes a typical topographer from a tomographer is that it gives you the option. The tomographer gives you the option of assessing or evaluating the back surface of the cornea. But for a regular topographer, that option is not there. So you just know that this is a pure tomographer or tomographer. I don't know if that answers your question.
Absolutely, thank you, Dr. Osazee. So
Okay, thank you, sir.
The question about corneal topographers being able to assess non-transparent structures. Do you think? I don't think that is captured in the module. Is that a question outside the module?
Okay, well, I
Okay,
think
well, he mentioned
maybe that was
that he was lecturing.
Yeah. I did actually. So maybe I will talk about it more when we are reviewing these pre-test questions. I actually
Okay.
mentioned it now. Yes, sir.
Okay. All right.
So I'll just check how many persons have submitted. Dr. Daffy, I can see your submission. Dr. Karachi, Dr. Ugochi. So I'm still waiting for that of, okay, Prof just sent hers. So I'm waiting for Dr. Lillian. Okay, Dr. Lillian just sent hers. Who else? Dr. Ugochi, I've not seen yours. Okay, I've seen yours. Okay, sorry. You actually first that submitted. So Dr. Karachi, okay, Dr. Karachi's own has come too. Who else have not submitted? Dr. Priscilla, good evening, ma. Are you still with us? I didn't see you for the test. Dr. Priscilla, should we wait for yours or we should go ahead to discuss the questions? Okay, so Dr. Priscilla, I guess she's multitasking. So moderator, sir, I think we can discuss this. Okay, Prof's hand is up. Prof, ma, please go ahead.
Thank you, Dr. Osazee, for the beautiful presentation. It's quite enlightening. And I think for me, this is about the first time I'm having a lecture on CTS. But looking at the first pre-test question, because actually the first time I looked at it, I thought it was talking about tomotopography. I didn't see tomography. So it was in the course of your presentation, I realized that there was a different word. But I think just like NC said, tomography is actually not in this, how will I put it now, in today's module. So I'm sure that for many of us, except for those who are already used to it, it's something that took me by surprise because I didn't even look at the word twice. I just thought it was topography.
Topography. that was the trick. That was the trick, Prof. It was intended.
I just saw the tomography now. I look at it again and say,
Dr. Ugochi, I just see it now.
we're carrying placard.
Do you know, Dr. Osazee? Prof, do you know instantly when I saw the question, Prof, when I saw the question,
yes,
I went straight to answer topography. Now
yeah.
I had to look at the question again carefully before submitting. I saw tomography.
Wow.
To change the answer instantly because I thought, what business do we have with tomography in the CTS?
Exactly.
So my immediate response was just topography. Sorry.
It's topography I'm seeing. I'm not seeing tomography, Dr. Osazee.
I know.
Dr. Abike, that's how students fail exam.
You go and wear your glasses. Go and wear
Exactly.
your glasses.
That's how students fail exam. Not adhering to instruction. not reading the question carefully.
Exactly. You don't read the question carefully. Oh my God. But I'm sure your post-test did not give the same answer, Dr.
Dr. Osazee is a lecturer, like Prof, like some other persons here, the likes of Dr. Daffy and all of them. So they know how to twist question. So if you have to read carefully.
Exactly.
If you don't read carefully, the difference might just be not is. They remove is on
Exactly.
to deceive you. Yeah. Just go ahead and write like one of the ones Prof have done. Prof did one of our exams, one of our pre-tests or post-tests.
Exactly.
I just went straight to answer. I didn't realize that something was
Please, can we edit our answer? Please, we have not discussed it. Dr. Osazee,
Not possible.
That's expo now. No.
Dr. Osazee, you know teach us tomography.
We learned the hard way, Dr. Habib.
It was not that prof said it. I had to say which one is tomography. I had to look at it and saw M. It's all P.
We learned the hard way.
Don't edit it. If I say edited, I will cancel it. I'll give you 0.
Editing is 0, -10, or -20. Anyway, I think it's interesting. We're all learning from this experience.
That's the beauty of it all. Yes.
Mm-hmm.
Right, so
some of us are even scholars and active learning.
It's been a very good and a wonderful evening. We actually did not take section 2, part 2 rather, because of want of time, so that we don't rush it. Like Prof mentioned, I wanted to say that for me, today was the first time of having these lectures. So it was a wonderful session for me. I've known we've always had this module, but I've not gone through it. And I'm just seeing it for the first time. So it was a wonderful time. I enjoyed myself. And a quick one, I would want Dr. Osazee to now walk us through the questions. I actually took notice of the topography and tomography in the pretest, but I was busy with other things. I couldn't really do much at that time. So when the time was up, for that time, I couldn't send my own because I knew the lecture was already going on. So I didn't bother with the pretest. So, okay, let not be that I've had the expo before I responded. And I did only post-test. But quickly, Dr. Osazee will walk us through it so that we can call it a day or a night. And hopefully we should go to agree on a time. I think maybe after tomorrow's session, we can ask if let's have an extra day. And God will help us. Especially God will help me. So Dr. Osazee, please take the floor.
All right, sir. Thank you so much. Thank you so much, Dr. Dapo. All right, so the question 1 there, I deliberately put it there because I know we already used the corneal topography since it's the corneal topography module we're talking about. And I deliberately put that there to give us some form of, to confuse us, okay? So, and I was surprised, I'm not surprised that some of us fell into that trap. So, and in my presentation, I actually took time to explain to differentiate these 2 terms, tomography and topography. And so for corneal topography now, we are looking at just the anterior surface. We are not looking beyond that point. Okay, so topography just talks about how flat or smooth, a surface is, that's all. But when you talk about tomography, you are looking at both the anterior and the posterior. So, and I actually give an example of the OCT, which is called a tomogram or an optical coherence tomography. Okay, and at that point, you and I know that for OCT tomograms, especially the retinal tomograph, or even the corneal tomogram, you see that it is actually both from anterior to posterior. So you have the information of the anterior surface, even within anterior surface, according to OCT, they will call you intra-retina. So the intra surface, and of course, the sub, or the underneath the surface. So it gives you information about the anterior and the posterior surface. So that's what the corneal topography is. So what I expected from your question or from your answers is topography gives you more information about the surface, it gives you information about the posterior cornea as well. And not necessarily giving you in 3D form. You can still put it in 2D because most times, just like I showed you in the during the presentation, you see how it gives you the front surface and the back surface. So it mustn't necessarily give you a 3D form. In as much as even your OCT tomogram, it's not in 3D. You and I know that it's not in 3D, it's still 2D. It's still flat, but just gives you, at best it tells you superior, inferior, nasal, temporal. So it gives you 2 images, inferior, superior, temporal, nasal. So it doesn't really give you a 3D form. However, you can also make it a 3D form if you want. Some tomographs have that ability to give you a 3D form. All right, so that's the first question. But the second question says, corneal topographers can measure curvature of non-transparent structure. I think I also mentioned that too. The answer to that question is true, not false. That's also another twist. I need some of us report for that too. So for corneal, I mentioned that the corneal topographs that uses the projection-based principle can actually measure surfaces that are not transparent. Okay, so we could see that because for the ones that only measures transparent structures are the ones that uses the reflection principle, where they shine light, or they shine the concentric circles on the surface, and the reflection from that surface is what is used to assess the surface. But for those that project, through a concentric slits onto the cornea, can actually go beyond the glass. So it doesn't need the reflection to give you the smoothness of the surface. So it can actually go towards the limbus and even some part of the sclera. So the answer to that question is true. Can corneal topographers measure curvature of non-transparent structures? The answer is yes, that's true. Number 3, normal cornea is dashed centrally and gradually flattens towards the dash. I think that's a good question. It's normal cornea, like we said, a prolate cornea is usually steep at the central and gradually flattens towards the periphery. So number 4, flatter areas are to cool colors, as steeper areas are to warm colors. So that's the answer to the last question. Okay, so if you
Sorry, Dr. Osazee, is it warm or hot? Hot color.
It's the same. Warm or hot is the same.
So I think we have more answers to. There are different ways of presenting that question number 4. Answer to question number 4.
Okay.
Because the warm color, you can use the warm colors, which are red and orange, to represent that. So flatter areas are to cool colors, right? And red and orange are hot colors. Is that not correct?
Say that again.
No, I'm saying that you say flatter areas are to cool colors, right?
Yes.
As red and orange are hot.
No, steeper areas are to.
Oh no, that's wrong now. That's
hold
statement is wrong.
Hold on. As red and orange are hot colors representing steep areas.
Okay, you
no,
no. I only wanted. Wait,
no, but red and orange are they not hot? Do they not represent steep colors?
Wait. Okay, hold on, sir. Can I come in now?
No, but did you get what I mentioned?
Of course, I do.
Good.
I do.
Right. Okay.
Yeah. So it is. This is like a brain teaser. I usually ask these questions or puzzle basically, to my children. There's a way it should follow. The first phrase should also sound as a second phrase. Okay. The only thing you need to do is just to fill in those gaps. So flatter areas are to cool colors, as steeper areas are to warm or hot colors. That's the answer to it. But if you explain it, meaning the same thing, I can still give you your mark. I'm not, in as much as you may not get full mark, but I'll still give you.
The essence is not to get the answer correct and explain what it means, the understanding. Because under the
you.
No, I get what you mean. But if you are writing, just a moment. If you are writing it, what is important is providing the understanding of what the question is saying, giving what we are trying to achieve in the whole exercise. Except we're interested in the technicality of the whole answer. I don't think our focus should be in the technicality of the answer. So that's the point I'm making.
Fine, it's fine. As long as you give me the right words, there's no problem. If you give me warm or hot colors and also give me steep.
Well, I'm not saying it to suggest I'm so keen in my score anyway, but I'm only saying that so that we don't
it's
base
fine,
our
it's fine,
based on technicality. So it doesn't matter if I score 1 or 2. That's not important to me.
Good evening, everyone. I'm so sorry I joined late, so I've been engaged in several meetings. Well done. It was a nice presentation. The part I made, very interesting. Well done, Dr. Osazee. Well done, everyone. Good evening, Prof. Good evening, NC. Well done, everyone.
Good evening, Dr. Priscilla. So one more thing, Dr. Osazee, the definition of this corneal tomography can come in various forms. I hope we also look at it, and not only the definition you gave. So think about it as well, because from what we know about tomography, it applies to something else from other than what you presented in your response. I'm just drawing attention to it as well.
You could share it to the house so that we can know what you mean. Dr. Ober. Dr. Ober, can you hear me?
Okay, yeah, sorry, I got distracted. I was trying to manage the background noise. So the word tomography has to do with sectioning and layers, right? So if you apply it to corneal tomography, you are looking at the sectioning of an understanding, having an understanding of different layers of the cornea, as opposed to surface analysis or topography of the cornea. So I needed to bring that to attention, and not just looking at the examination from the anterior to the posterior surface, or looking at the two different surfaces or areas of the cornea, that is this anterior and the posterior.
Doctor, I agree with you on that.
Like a three-dimensional view.
I agree with Dr. Owe on that definition. Sectioning, tomography has to do with sectioning.
But if you hear
what you understand by sectioning, I don't think is it different from what I mentioned? Can you differentiate it from how I explained it?
Somebody was saying something about a 3-dimensional view. Somebody was saying something about a 3-dimensional view.
Well, I didn't understand you clearly when you were trying to explain that first one, but I didn't quite hear anything about the concept of tomography, just like I mentioned now. So I didn't hear that anyway. So I was trying to draw your attention to it.
I think thank God this meeting is recorded. So maybe when it is ready, we can all review it. So what I explained again about tomography, I think for those of us that said section, when you say section, okay, section is, it gives you an entire view of that image itself. But for OCT gives you section. When you say section by section now, it gives you one section of the one part of the eye, okay, one tomogram, and goes to another aspect and give you. So it gives you how will I explain now? Section by sectioning of the entire retina. Okay, so that's what it means by sectioning. Not necessarily tomography in itself talks about information about the entire area that you're looking at, both from anterior to posterior. That's what tomogram is.
Doctor says like a 3-dimensional view. Is it like a 3-dimensional view?
No, three-dimensional view is different. When you talk about 3-dimensional view, you are looking at depth. It's different from what we are looking at now. Okay, depth is not what we're looking at now. It just gives you an information, just like you slice, you you slice something from the superior or from the anterior surface down into the posterior surface. Given it's still like tomograph, all the tomographs are saying they don't give their information in 3D view. 3D view means you are looking at it having some form of depth, having some angles towards it. I've seen for OCT, I've seen a corneal tomograph, a retinal tomograph in 3D view. Okay, I've seen that, and that makes a lot of sense. But the usual ones we have on our retinal map printouts are all in 2D. They're flat. The best it gives you is that it gives you inferior superior, how it's like from nasal to temporal. That's all you get. These are just additions to what the machine can give you. But the main information in tomography is that it transits, it goes beyond the surface and gives you internal to posterior structures or information about that tissue. That's it basically.
Dr. Osazee, I think maybe
So
your
it's the same
explanation.
If someone says
I didn't know you are
3D,
still talking.
that is
Dr.
still okay.
Osazee,
That is still correct.
Dr.
Oh, sorry,
Osazee,
someone is saying something.
okay, sorry, NC. Dr. Osazee, your explanation is correct. Maybe it's the way you said it the first time that wasn't so clear. Because when you talk about tomography, we're talking about sectioning, either from the top to the bottom or from the anterior, maybe to the posterior. But it has to be a cross section of the whole image that we are talking about. That's my understanding. So, but from the way you are explaining, I think we are practically talking about the same thing.
Yeah,
I don't know. Maybe the NC, because it has to be a cross section from maybe point A to point B, the superior to the inferior, the top surface to the bottom or something. But it must be a cross section. Why topography is just the top? We are looking at just that anterior part alone. That's my understanding.
That's absolutely correct. So to also add to what Dr. Karachi said, I think Dr. Karachi is also right. It can be 3D. I think you also mentioned that it can be 3D or 2D. So if she says 3D, I don't think is wrong as well. So, but it doesn't have to be 3D. I think that's the point you mentioned.
That's the point I'm making. Yes, that's the point I'm making. 3D is just an addition to make it look real and make you feel it better. But it mustn't be in 3D. It can also be in 2D.
It's okay.
Right.
Our time is fast spent.
Thank you.
Our time is fast spent today, and it's been a wonderful moment and engagement and times of laughter today. And Dr. Saze, thank you so much for anchoring this. And I want to thank everybody that made that time to be here today again. Quickly, I'll want our Prof to have a word from Prof. And in particular, the timing to take the part 2 of this lecture will be very, very needful. If we can't get it tonight, then maybe before tomorrow, before we finish tomorrow, if you want to know if it's by Monday evening, we are taking part 2, it will be good. So quickly, I'll hand over to Prof and possibly our NC. I will call it a night. Prof, ma.
Thank you, Dr. Duffy. I think we still have the national upgrade for next month, if I'm not mistaken. That should be the 3rd national upgrade. And I think the appropriate time for part 2 of this CTS to come in will be in the 3rd national upgrade, if that is taken by the House. That's my suggestion.
Okay, so noted, ma. Any other closing words before our NC comes up so that we could call it a night?
Well, I think I agree with Prof. We have stretched this particular upgrade for too long now, and a lot of us needs to have some time to breathe. So let us move it. Let's move it to the next one. I agree totally with that. So that we end everything tomorrow. But Prof, some of us are agitating that this the next upgrade should be next year. Those of you that said so, please say.
Yeah, so I
Dr. Karachi.
Dr. Karachi, you go to National Assembly and enjoy voice vote.
Dr. Osazee, I think we can have an opinion poll on that.
No, it's important to conclude. We finish it not next year, because next year is another upgrade. Though. This upgrade has to be every year, because these ones we are doing now, we have to repeat them next year. So it's not something we do this year and leave it for another 2 years or 3 years and come back again. So we need to do it. I think it's something we'll have to decide.
My NC, sorry, I think we are going to have the pre-conference coming very soon. And we've had this like 20 days non-stop, for this upgrade. I think if we give a break so that before we start the pre-conference, that'll be fine. But if we go ahead with it and pre-conference, it will take a toll on us. That's my suggestion.
It should come later. I agree with you completely. It's taking a huge toll on all of us. I agree with you completely. And that explains why some of us are not able to meet the time. I can see about 6 persons only have been consistent, because it's not easy to manage. Consistently follow up with this module, this upgrade, and do other things that we are engaged in. So I think it's something we can do later on. Don't have to do it the time was scheduled already.
But I have a suggestion, NC.
Okay, Prof.
I know that for quite a number of us, it's not easy pulling through this, upgrade. For me, I had a major breakdown in between, and I have some health challenges. But I think if we are to go by the opinion of the House, we should have a break. The upgrade we are not able to take this time around, those modules, I think we can start with them next year, if that is the opinion of the House. We mustn't take all the 46 modules at a stretch. It's not easy. That's my humble suggestion.
Okay, I think we're saying the same thing essentially, Prof. So I'm saying there's need for us to conclude and complete the modules, but we don't have to. We can stagger the modules, so as much as we can, so nobody will break down. I agree with you. So the timing is now the issue. So we can present an opinion pool and see what works for everyone. We can work with that.
And I think that also we need to also have in view the national upgrade for the other cadre, and then our TTT, another event that are lined up for the year.
In fact, while you are speaking, I've been thinking about other ways we can go about these upgrades going forward, maybe subsequent edition, maybe subsequent years, so that we don't have to do not weigh us down so much, because I can see a lot of us are struggling to meet the time and be able to go through the program. But I'm just thinking if there are other ways we can make it a bit more flexible, and how we can also accommodate those who missed out in the modules, the different days in the upgrade. Are we going to leave it that way? No. So they should have catch up to meet up and cover all the modules they missed. So these are things we can think and see what works for us. But I think we can discuss more on the chat, so we don't drag the meeting further. It's almost 10:15 Nigeria.
It's nothing.
Because we have a lot to discuss. We even have the TTT to work out. We have the other upgrade for other cadres of mentors to talk about. We have the pre-conference to bother about, and quite a lot. So, and sadly, we don't get paid for all of these things, even though, yes, we're all indirectly we're benefiting from it, but this is not the primary business we have to do. We have other engagement that should take priority over this one. And I appreciate all of us for the time and the effort we put in to make this work, particularly Dr. Osazee. I don't know how he does it. Yeah, I'm not sure.
Something else.
I'm not sure how he does it. Maybe he can present a seminar on that one entirely, so all of us can learn from him. And Prof to all of us, all of the persons who have been consistent in this. I'm not sure how we're doing it. Being Dr. Karachi, who is doing Omogo and still able to do it. Who will I leave out? Dr. Lillian, Dr. Priscilla, Dr. Gochi, and every single person. Dr. Daffy, honor of, and all of us who have been consistent.
Dr. Orwell too. Dr.
No,
Orwell,
I don't. I know. I had to change my schedule entirely to accommodate this. I know it's coming at a huge cost, but I think it's worth the time and the effort. To be honest, I've enjoyed every bit of it. Prof, I think we can continue on the platform so we don't delay people further. Drag them.
Yes. We'll do that.
Thank you, everyone. Thank you so much, everyone. I think we can call it a night. We'll meet tomorrow, and the final remarks will be said tomorrow, and all of the projections as it concerns the next upgrades and all of that. So I'm sure that tomorrow we'll have everything. So tomorrow will be the last day by the grace of God. Thank you, everyone. You have a good
Thank you, Dr. Osazee.
All right. Good night, everyone.
Good night.
Thank you,
Good night,
everybody.
everyone.